Well, good morning, everybody. My name's Paul. I have Dr. Lewandowski over here to my right. Dr. Patterson will be showing up in a little bit. We're going to start off with some introductions and then go into staffing, see if we have any cases that we need to review, and then we'll hit the PowerPoint where we're going to be discussing diagnosing opioid use disorder and stigma promoting language. And let's start off with some introductions. We'll start off with who's out there, and then also I want to know who got up early this morning and saw the moon, and did you feel that season change? So just a couple of words about how you felt with that season change. Because it seemed to me like summer was leaving and we were starting fall. So let's start over with, we have a list or
Dr. Postman?
Dr. Postman.
Good morning.
Good morning.
Good morning.
Actually, I didn't see the moon this morning. It's too cloudy, but I did go up to Oregon to see the total eclipse of the sun, and that was just unbelievable.
Wow.
Yeah.
Nice.
This
Very nice.
experience ought to be duplicated any other way.
You know, I heard that the next total eclipse will actually be in Reno in 2045.
No, I don't think it's here. I think it goes across.
Does it go across?
From Texas? Yeah.
Okay, I thought it was 2045. I don't know that I'll be here to see it anyways. But yes.
Well, 7 years now we'll go through. 7 years now we'll go through Texas and New England.
Yeah. Outstanding.
Next.
Dr. Van Gilder.
Good morning.
Hi there. I'm out doctor out here. I have fourth year medical student, Spencer Johnson. Good morning.
Wonderful.
All right.
Steve.
Oh, Steve.
Great.
Okay. How about Mel?
Mount Grant.
Oh my gosh.
Mount Grant Hospital.
Okay.
And we don't have audio there. Len Chrysler.
We started off so good. We had the eclipse. Now we're meeting fourth year. Oh, where's everybody going? All right, next.
Penny Haas. Hi, Penny.
Penny? Oh, good.
She's so burning.
Henry Soloway.
Well, I hope these are technical difficulties. And maybe you can hear us because we have to go into staffing. Who's on the bottom?
Yeah, and who do we have joining us by phone? 702 area code.
Okie dokie.
Wait, are you there? Can you hear us? All right. Just go ahead.
Right? Any staffing, any complicated cases, anybody that you're having questions with, especially with opioid use disorder or somebody who might be taking a little bit extended amount of opioids, volume or time-wise, any complicated cases that you have? Okay, well, let's start off with the power. Oh, I'm sorry. Dr. Lewandowski. I didn't introduce you. Go ahead.
Hello, good morning all. Good morning all. And yes, welcome.
Dr. Lewandowski is a psychologist. Been practicing for 35 years.
Yes, just about. Work with people with chronic pain, persistent pain problems, and I have a PhD in psychology, kind of a cognitive behavioral perspective and approach to helping folks with health problems, and particularly chronic pain. Thank you, Paul.
And Dr. Patterson?
Yeah, I'm Dr. Dennis Patterson. I'm board certified in physical medicine and rehabilitation and pain management, and been doing it for about 10 years now. My practice is, 99.9% patients with chronic pain.
And yeah, so wealth of education and experience here. Please use us to maximum, to maximize your investment of your valuable time. And really, thank you all for being here. My name's Paul. I'm a licensed alcohol and drug counselor. And so when it comes to diagnosing different substance use disorders, this is kind of what I do. And the idea of the diagnosing, if you've been following along the series, we started off with screening, then we went to assessing, then we're going into diagnosing. And so this is where we try to get a snapshot of where the whole person is. We're looking at them mentally, emotionally, physically, and spiritually to help them move through the situation that they're in. When I say a snapshot, and all the work that we do is disposable. It's to recognize and build an alliance with that client and be part of their team so that they can move through the stages of change and progress. So if we just start with an assessment or label them, it's like taking the first step of the 12 steps or taking the first step in any kind of treatment, which will actually add to the person's issues. If I say, oh yeah, they're a heroin addict, what do you think? What comes to your mind immediately? That's where the stigma comes in. So we have to watch our language. We have to recognize and explain to the person that we're there to work and walk with them honestly to get to the better life that they have the potential for if they have the substances out of their system. The payoff, they have to recognize the payoff. They have to feel the payoff, and they have to see it from the relationships around them, which will grow stronger. Everybody, when they come to see me, it's they're not having fun anymore with their use. And the number one motivating factor to help them move through this time in their life, which can be really dark, is their families, their relationship, and really love. That's where we have to go down to help move through these disorders. When we're looking at addiction, addiction is not a diagnosis. People throw around the word addiction like it is a brand. And what I really like the word about brands is when I say Coca-Cola, what do you think of? Or when I say Toyota, what do you think of? Those guys spend millions, billions of dollars working on their brand. Now our brand, our individual brands are being worked on every single day. Every day that we get up and we go to work, we show up, we suit up, we do our job, we're working on our brand. So we have to recognize that individual is bigger than the disease state. The individual is, like if we said, oh yeah, the diabetic over there, or yeah, the person with the heart disease over there. We don't treat people like that. We usually treat addiction, though, in that kind of shadow, if you will. But addiction is a chronic relapsing brain disease characterized by compulsive drug seeking and use despite harmful consequences. And when we're looking at the harmful consequences, nobody is more aware of the harmful consequences than the person who's actually experiencing them. They don't want to hurt people. It's just It's part of the package deal when you get to this level of using. So it's not considered a specific diagnosis in the 5th edition of the DSM. That's a Diagnostic and Statistical Manual of Mental Disorders. This is what we use as a manual by clinicians, and it contains all the descriptions and symptoms of all mental disorders classified by the American Psychiatric Association. Substance use disorders. So we're not using abuse or dependence anymore. We're looking at the DSM-5. And DSM-5 describes a problematic pattern of use of an intoxicating substance leading to clinically significant impairment or distress, manifested by at least 2 of the following occurring during a 12-month period. So we're going to go through the 11 criteria. If you hit 2 to 3 of these criteria, you are considered to have mild substance use disorder. If you have 4 to 5, moderate substance use disorder. 6 or more is considered severe substance use disorder. Now, recognize, when we take this individual picture of this person, this snapshot, what's going to happen is we want these diagnoses or the criteria to go away. And all of these criteria will go away. Craving is usually the last to go away. But everything comes back, just like everything was systematically destroyed through the use. Now everything kind of bubbles back up into health. So, substance is often taken in larger amounts or over a longer period than was intended. So if somebody comes to me and they have 3 DUIs, well, that's one. There's a persistent desire or unsuccessful efforts to cut down or control use of the substance. Yeah, every time I have a hangover, I say that's the last time. I'm never going to drink again, right? That's 2. A great deal of time is spent in activities necessary to obtain the substance, use the substance, or recover from its effects. My meth people, I've been up for 3 days. What have you been doing? Shooting, staying in the basement with the curtains drawn, looking out, afraid, paranoid. That's 3. Craving, a strong desire or urge to use the substance. This doesn't go away. A lot of times, like for benzodiazepines, cravings can manifest both physically and psychologically. So we have 2 different types of dependency going here. Also, there's a behavioral craving where someone even gets to the point where they start to anticipate not feeling strong or thinking that they're going to feel some discomfort, so they'll reach out. That's 4. Recurrent use in the substance resulting in a failure to fulfill major role obligations at work, school, or home. How are your grades? Have your bosses ever talked to you? Have you ever called in sick? What's your partner or significant other saying about your use? They think you should cut down? 5. 6. Continued use of the substance despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of use. With alcohol, do you ever get into fights when you are drinking? Yeah, okay. 7, important social, occupational, or recreational activities are given up or reduced because of use of the substance. You miss your kid's basketball game because you're using or drinking or whatever. Recurrent use of the substance in situations where it's physically hazardous. Have you ever used your substance and driven a vehicle? Use of the substance is continued despite knowledge of having a persistent or recurrent physical or psychological problem that's likely to have been caused or exacerbated by the substance. Easy way to cut through this one. Do you know what's bad for you? 10, tolerance. So, do you need more of the substance to achieve intoxication, or do you get less of the effect with the continued use of the same amount. And then withdrawal. So many withdrawal symptoms, headache, hangover, blackouts, delirium tremens, the list goes on and on. And so you can go through a list of the withdrawal symptoms or the substance or a closely related substance is taken to relieve or avoid withdrawal symptoms. Now, with substance use disorder, you can put anything, any substance in that little blank. So, substance use disorder. So this person has four criteria for alcohol. So what would you consider that person at that point? They would have moderate alcohol use disorder. If they had 7 for amphetamines, methamphetamine, then it would be severe methamphetamine use disorder. If they met 2 of the criteria for cannabis or marijuana, then it would be mild cannabis use disorder. So all of the substances can be put into this, and we just do mild, moderate, severe. And again, the idea is we want to recheck this and continue going back to it to see, as time goes on, have the criteria gone down. So this is one marker. This is one thing that we do, but it's a big one. DSM-4, like we discussed before, they have alcohol abuse and alcohol dependence. Each of those had their own criteria. And now we go into alcohol use disorder. DSM-4, the diagnostic criteria for abuse and dependence were distinct. Abuse criteria within a 12-month period would receive the abuse diagnosis. Anyone with 3 or more of the dependence criteria during the same 12-month period would receive a dependence diagnosis. So it was a graduation from abuse to dependence, and then you can go back down into abuse. Remission, timeline specifier. So remission is abstinence for at least 3 months, but less than 12 months.
Yes.
And then,
Okay.
what's that? Oh, is there a question?
Do you ever,
Okay.
Dr. Postman, we can hear you if you have a question.
oh, sorry, I just rocketed it. I'm sorry, I was not
No
ready
problem.
for the presentation. Sorry.
Oh, that's okay. So we have early remission and then remission. So early remission is at least 3 months, but less than 12. And then you have remission, which is over 12 months. In a controlled environment is a specifier that you put for your people who are incarcerated, because generally they're not supposed to be able to get substances in there, or on maintenance therapy. So we have maintenance therapy, especially for opioid use disorder, where a person could be on methadone, but you want to specify that, or Suboxone or Vivitrol. And so you want to be very clear about where the person is, what medications they're using. Then we have levels of care. So when we're looking at each individual, we're looking at keeping the puzzle moving. And just like their diagnosis will go down, we want their level of care to go down. And we always try to go with the least appropriate level of care. So if the person has a couple of criteria and you're thinking, well, early intervention, what is that? That's education. they can sit down and speak with somebody. You can give them some information to hit home. Ask them how it's impacting their life, if they'd like to stop. One of my favorites is when I ask them to vision themselves out 5 years and then give them self-advice and see what older them would say and what path older them would take. Outpatient treatment. Outpatient treatment is 2 sessions a week, 3-hour sessions, and that has an individual counseling component and a family counseling component. Intensive outpatient is 3 sessions a week. Those are 3-hour sessions. That is also with a family component and individual counseling. Residential or inpatient treatment is a lot of peer support. It's just like it sounds. You're living it. You're in there in the residential area. It's usually a 28-day program. There is physicians, psychiatrists, counseling. The whole world is set up around eating well, learning how to take care of themselves, getting the messages that they need, creating the coping skills that they need, recognizing that they're going back to an environment that hasn't changed at all, and what they have to do is a lot of work. And it takes 24/7, and you're working with peers too, who are all trying to get on the same path. And so there's a lot of power in the residential inpatient treatment. Here's an interesting thing. I was trained in Hazelden Betty Ford, and I got my master's degree in addiction studies from Hazelden. And when we're working with residential inpatient, we did a outcomes kind of survey. And so everybody that we let go back into their environment, we calculated that after a year, we considered a year to be successful if they were abstinent. What percentage do you think were successful after going to inpatient?
Like 50%.
Nice, perfect. Yep.
I'd say 50%.
Hey, you got it right too. Boom, boom. 50%. I think it costs about $38,000 now for that 28-day month. So 50%, and that's considered one of the leading treatment facilities in the country. So that puts things into perspective. Medically managed intensive inpatient treatment, just like it sounds, you're being hooked up. You have a nurse that's available. You have doctors who are watching your vitals. You have all kinds of stuff. So, had a dear friend this last weekend. He goes in to have he broke his fibula getting into a car. 76 years old, diabetes, overweight, hypertension, high blood pressure. He goes in to the doctor. First doctor he says, yep, we need to operate. Now, when I worked over with athletes, usually with the fibula, it's not a weight-bearing bone, and so they wrap it up a lot of times, but he's and let it go. You're the physician.
Yeah. Say, usually a fibula, unless it's an open fracture,
Yeah.
you can heal it by casting or immobilize it.
He wanted to cut. So, he does. But before he does, he gives them the medication protocol that he has to follow. Take a Percocet, this is a 10-325. Half an hour before the surgery, or no, 3 hours before the surgery. And then after the surgery, continue to take this pill every 3 hours. Not as needed.
No matter what.
Not for pain, no matter what. So his lady has his alarm clock set. 1 o'clock in the morning, take your pill. 4 o'clock in the morning, wake up, honey, take your pill. Boom, boom, boom. She gives me a call. He's looking gray. He's clammy. He's sweaty. He's completely out of his mind. What I mean by out of his mind is when he's not nodding off, he is incoherently babbling, and this is a very intelligent guy. But they were following the doctor's directions. So call 911. He goes to medically managed detox. Took him 3 days to get all that stuff out of his system. And here's the interesting thing. The opioids knock him out. So it knocks him out. He's he's not coherent enough. It's dehydrating him severely. Everything's being constipated. He didn't have a bowel movement for 4 days. His spine, he couldn't feel anything because of the mu receptors in the spine and the brain, right? Yeah. The acetaminophen, the 325 milligrams,
It's overdose.
killing his liver, shutting down the liver. After the liver comes the pancreas. So this is somebody who also had prostate issues previously, and so we're looking at the whole digestive tract. So it's not 1 + 1 = 2. Now we have all of these complex compound issues that are going on in this person who is overdosing by opioids and acetaminophen, right? Is this your typical heroin addict? No. So I tried to get some naloxone, see what's going on with the pharmacies around town. It is tough. It's tough to get that. They'll order it for you. Yeah. But the stigma, and we're going to be getting into stigma, of what's going on with opioids is rampant throughout not only our community, but throughout the country. And when we're hearing opioid use, I want you to take it away from this is an individual who has a substance use disorder to this is somebody who's trapped right now. He was held hostage by this substance following the doctor's orders specifically. And it could have been a typo on that protocol for his medications. So we'll see. He's still not back, but that was my Labor Day.
Wow, really? He's still hospitalized?
No, he's back in his home, still using he's having visiting nurses come over. Yeah, takes a little bit of time to get that stuff out, and you can tell when you talk to him, he's not back yet.
Yeah,
he'll be back. I hope. Yeah. Each level of care indicates the appropriate treatment settings, admission, staffing, services, and discharge criteria for 6 dimensions. We'll go over the dimensions. That's pretty much where I live when I'm with somebody. I'm always checking the dimensions. But do you see how each level of care is one is more intense than the other? The idea is we get them into medically managed intensive inpatient treatment. We want them to get into level 3 from level 4. That's how we can gauge success. That's how we can look at our progress. We look at inpatient going to intensive outpatient. So if you're in an environment with 24-hour monitoring and structure, and then you can go back into your community and test out what life is like, what work is like, what relationships are like without your drug of choice while still getting the support every week from a group setting with the individual counseling to take care of your individual needs and the significant other or the family member involved too. Why is the significant other? Why would that be important?
Because they could be an enabler. And so you want to get them involved, and you want to make sure that they're not going to enable the patient after they get back in their social situations.
Absolutely. Do you see that a lot?
Oh, yeah.
Yeah. Do you see that a lot, Dr. Lewandowski?
Absolutely, yeah. In the form of being overly solicitous and trying to show that they care, perhaps.
Oh, okay.
That dimension's interesting with pain and with the medications.
How about the policeman? How about the partner who's changed the relationship from spouse to cop? From I know you're doing it, I know you're sneaking, I know you're out there, and you're thinking about it, I can see it. How does having that person involved in the treatment or the counseling help?
It's usually very helpful. I find that to be less often now. Usually it's a codependent personality, and if the one spouse has a problem, the other spouse probably has a problem, but maybe at a lesser degree. Okay. And so I find it difficult to find a spouse that will be the policeman at times for my chronic pain patients. I wish they would be more that way. But then again, if they probably take that role, and after the person probably gets sober, they probably end up divorced. There you go. One spouse probably, does not like the other spouse after them playing that role with them for a period of time.
Yeah. There's a love-hate relationship there. I love you that you're taking care of me, but hate you that you're taking care of me. Correct. And then we also have we're upsetting the family dynamic here when we bring in the significant other. So the other person has needs too, needs that have been met, and there is a payoff on all of these behaviors, all of these different modes of behavior. There's a payoff. So we have to recreate the whole family dynamic in a healthy setting. Then you can see where it goes from IOP to outpatient. So now we're going down. It's only a couple hours a week. And then if they need consistent peer support, that's where they're flying. That's how we move through these different levels of care. We can move up and we can move down. Now, if they relapse,
can you hear
me? What's that?
Can you hear me?
I can.
Yes, go ahead.
This is you brought up an item, namely iatrogenic cause for this man's problem. Do you have a moral, ethical, or legal obligation to report this to the Board of Medical Examiners? And should this be considered?
What's the question? I'm having a hard time hearing you.
I'm asking you about, this was obviously an iatrogenic, doctor-initiated problem, which is not uncommon. Do you have a moral, ethical, or legal obligation to report this practitioner's behavior to the Board of Medical Examiners?
I think he's talking about the
scenario. The scenario you're talking about, your friend over the Labor Day weekend. And the physician giving the patient that advice, since it was iatrogenic, the physician initiated, should you report him to the medical board?
Let me throw it to my panel. What do you think?
Well, I mean, it certainly raises an interesting question. Was the physician prescribing within the policies of what would be medically considered, I think, a standard of care? Time contingent administration of medications, I think, is an option. But it does raise an interesting question if indeed, you should bring the board into, considering the examination of this particular provider's prescribing patterns, if indeed this is one example of one of several that he does. But I don't know. Let me defer to my medical colleague.
I'd say it's a case-by-case situation. If you see that this doctor has repetitive behavior of doing this, then that's probably something that I would consider turning into the medical board and having them have a look at it. I don't think you're under any legal, moral, or ethical obligation to do so, but I think if you have concerns that they're harming patients in your, you know, in your community, that you should take it upon yourself to promote some action. I wish I could say that Paul's story is the exception, but unfortunately, you know, I see patients all the time in my practice who have some type of surgical intervention planned, and you know, we will call the practice or the surgeon's office that is planning the surgery. We will notify them that the patient is in pain management, and usually what we do is we create a post-op pain plan, where I'll actually temporarily increase their medications or figure out a way to cover their pain, tell the surgeon not to give them medications, and we'll give them a tapering plan so that 4 to 6 weeks after the surgery, we have them back on at least what they were before, if not less medications prior to the surgery, especially if that surgery is supposed to alleviate, you know, why they're on chronic opiates. What's blowing me away is that there are certain offices that when we tell them we're going to do that, you know, some they love it. Oh, this is great. We don't have to prescribe them anything. If they have a pain problem with their pain afterwards, they can call you, not me. That I don't need to be bothered. And that usually goes very, very well. There's other offices, though, that I'm blown away with that they, oh, no, we've got this. We've got this. We don't want your help. And then they end up taking over the patient's care. And I'm blown away by when the patient returns to me in 3 to 6 months about looking at what they were prescribed over that 3 to 6 months and the excessive prescribing. And then a lot of times the patient will return to me, they'll be on twice as much pain medication as when they left me, and you know, but yet they had a successful outcome of the surgery. And that blows my mind too, because now I got to be the bad guy to be like, well, hey, we need to cut you back down to where you were before you even left here. And usually patients get angry with that, you know, because their surgeon would prescribe them those medications. So Len, I'd say, unfortunately, you know, I usually see more of that case than the opposite case. Surgeons want to control what they prescribe to the patient. They want, and I'm blown away by how much they will prescribe during that period.
It made me think too, the issue of acute versus chronic pain. This may be an example of post-op, very acute pain management, in which case, as a mental health provider, I would certainly back off and say that's the surgeon's prerogative. If, however, this every 3 hours was now a chronic condition and it's 6 months after the surgery, then I would, based on my training, say that doesn't seem quite right.
Yeah, and this is why I brought it up to our experts here, because I owe it to the physician to talk to him. So we're meeting with the physician, all of us, on Friday. And so we want to make sure that this doesn't happen again. If it was an oversight, if it was a typo, if it was negligence, if it was malpractice, I mean, between the moon and whale droppings, who knows what the truth is? And so we have to get us all together as a team and figure out what's going on here. How do we impact this, especially so that it doesn't happen again? Because we almost lost my dear friend. The emergency room in 3 days in ICU is pretty serious, especially with the dehydration, the liver, the pancreas, all of the different things. And then there's the health of the liver and the pancreas and all the digestive areas too. There's a whole bunch of investigating that needs to be taken care of before actually going for a punitive or board kind of consult. And I think if everybody's on the same page, more positive can be coming out of this situation than negative.
You know, if I could add, Paul, too, it highlights, I think, the new law that the governor signed, AB 474, which I guess requires physicians, even doing surgery, to take a look at the psychosocial and opioid risk of that patient for the use of opiates post-surgically. So it just raises, I think, the awareness of looking at, you know, who may be vulnerable out there. I'm not saying your friend may be, but this law may be a good practice for our.
That's a really good point. That's a really good point. Now, here's another thing. He's opiate naive. I mean, his body has never had an opiate in it, and he drinks like 1 beer maybe a week or 2.
So he probably wouldn't have been identified as high risk.
My other question would be is what strength was the medication?
It's a Percocet 10, 325.
And that blows my mind too. I can't tell you how many times, like an opiate naive person, why wouldn't they start them out at the lowest possible dose and take 1 to 2 as needed versus I'm going to give you the strongest possible dose and you're going to take it no matter what. It sounds to me as though this physician just didn't want to be bothered on the holiday weekend.
Possibly, but what bothers me too is I didn't mention that he had Norco as backup. And so
It makes no sense either to be prescribing 2 short-acting pills to a patient in this scenario.
well, especially when we're closing down the liver, then you're extending the half-life.
Yeah.
So opioid half-life of what, 17 hours now is extended because you can't calculate because it's not getting metabolized.
Correct.
So there's all kinds of different things that we have to look into. Anyway, all right, so I brought up a case. Everybody owes me a case. Let's go back to the PowerPoint. All right, 6 dimensions. This is where I spend a lot of my time. We want to make sure these 6 dimensions, I work with Native Americans who actually have a 7th dimension, that's spirituality. And so the first dimension is potential for acute intoxication or withdrawal. So when's the last time you used? What did you use? Now remember, benzodiazepines can have withdrawal symptoms months after the person has ingested it. And so each substance has its own personality, and you have to be aware of what those substances can do. Biomedical conditions, what medical conditions do you have? Do you have a broken leg to heart issues to stitches? Emotional behavioral conditions, complications, agitation, depression, even non-motivation. All of these things are going to perk up and down as the substance is being removed from the person's body. Many of the emotional roller coaster is actually attributed to either using the substance or getting the substance out of the person. So a lot of this can be expected. Treatment, acceptance, or resistance. So we'll go through the stages of change. Relapse or continued use potential. This is a big one. How long have they been using? What have they been using? What amounts have they been using? Have they failed and or not succeeded as much as they wanted to in past previous treatments? All kinds of things for what kind of education do they have? What kind of coping skills do they have? Then we look at recovery environment, which has its own dimension. Who are you living with? Are they using? Are they supportive of your abstinence? What are you doing on your weekends? What are you doing for fun? Spirituality, do you do it? Do you believe in a higher power? What's your conception of your higher power? All different kinds of things there. So when we're looking at this gives us the idea of where the person is, and we're continually taking snapshots just by revisiting it. Stages of recovery. So 1 month to 1 year, consider the person in an early stage of recovery. If they've been using for 10, 15 years and they stop for a year, consider them to be fragile. Focus on abstinence first. Celebrate those abstinences. Every single day is a celebration. When their head hits the pillow, they can say, I did it again. This was a good day. No matter what situations life brings, you can know that you did it on your own, giving it the best shot that you possibly could. There's high relapse potential here. Just goes without saying. They build a relationship with their substance. So we think about screwing up that relationship, and a lot of times a relapse can actually be one of the most beneficial things that a person can experience, because they go back to where they were before and they recognize how dark it is and how it doesn't taste the same or how it doesn't feel the same, and then they get that guilt and remorse. which gives us the potential to get in there, that little sweet spot where we can get in and then continue to move forward. They don't go back to early intervention if they relapse. They can go into a stronger stage of change. Let's see, where am I going? Middle. This can last a lifetime. After a year, all revolves around lifestyle and environmental changes, and it really deals with the person. Person's been able to see 4 seasons right now, has been able to go through a complete year, and they can see their personality trait changes and start recognizing the payoffs. And yeah, I have more money in my pocket, people like me again. I'm actually starting to do activities that I like. I'm not comparing sober life with a using life. And I'm getting more towards by brand. And then latent maintenance, clients work to maintain abstinence while continuing to make lifestyle changes. But here's the thing, we get somebody who's new or early in recovery and we throw them into AA without explaining what AA does. If we do that, then they're listening to a whole bunch of old white guys telling their war stories and they're getting absolutely nothing out of it. Right? AA is more like maintenance. Now, yeah, you can get in a group of people who are all trying to do the same, but it's not peer support. And you know what? There's not money that's being changed, and there's no power structure here. So you get what you get. If they're going to go, and I believe AA works with a lot of people. Some people, that's their whole recovery, AA. Some people hate it. Some people grow into it. Some people use it moderately. It all depends on the individual. And that's where the healthcare provider comes in to figure out what's going on. Because if it doesn't work in early, they can grow into it, give it an honest shot. If it's still not working, there's smart recovery. There's all different kinds of things that you can work on. And if it doesn't work today, it might work 2 years down the road. Who knows? We're just constantly revisiting where they are, keeping the puzzle moving. Stages of change. So you recognize this. So see how this is a puzzle? We have the treatment side. We have the level of care side. We have now the individual side, like where are they coming from mentally? We have the diagnostic side. We have all of these different things that we have to keep up in the air. We're spinning these plates. So pre-contemplation, this is an easy one to recognize. Yeah, I don't have a problem at all. Or yeah, I have a problem, it's you. Get off my head, or my parents. Get off of me. Leave me alone. There's no problem here. It's just a little pot. Contemplation. But you know what? Every single time that I have an issue or a problem, this substance is involved. Maybe there's a correlation here. I'm contemplating that maybe I should stop this stuff, or at least it's having a negative impact on my life. Preparation. You know what? I'm going to do it. I'm going to go to counseling. I'm going to go to meetings. I'm going to take care of myself. I'm going to start exercising instead of using. I'm going to get away from this stuff completely. I'm going to do it. I'm really going to do it tomorrow. Action. They're actually doing it. This is clunky. This is, especially in the beginning, it's like a new foal trying to get their legs. There's mistakes. There's problems. It's beautiful. They're coming to life, and they're making all kinds of mistakes and tripping up, and this is really where the healthcare provider can help them celebrate and see how courageous they are. You go into a new room with new people, and you're going to be talking about real emotional, sensitive stuff. That takes courage. They're making the deal, because right now their words mean nothing. 1 to 100, about 5%. I'm going to stop. I'm never going to do it again. Blah, blah. Their loved ones have heard that 1,000,000 times. But when they say through their behaviors, I haven't used, they don't have to say it verbally. They're screaming to their family, I love you. I care more about you, family member, than I do my substance, and you know how much I love my substance. Maintenance. This again, like we were talking about, after a year or so, then they're kind of getting into a system. Make sure that system doesn't turn into a rut. We have to keep on going and growing. We have to keep on exploring and using our potential. Because what was good for us 2 years ago is completely different than it is right now. And where we're going 2 years from now, none of our business. Now, we can have goals. Goals are just dreams with a deadline. I read that on my daily thing this morning. Whatever that calendar thing is. And then we talked about relapse. Relapse, again, is a stage of change. We don't need to revolt from it or discipline it, or we learn from our relapses. How did it feel when you went back? How was, what's your mental process like? What's your self-esteem like? Now let's talk about stigma. Oh, good. I have, 7 minutes left? Yeah, okay. Go over stigma. When somebody says an addict, when somebody says something, the person brands themselves. They label themselves. They are bigger than the substance use. They are much more than any of their primary or secondary characteristics. That's what makes them unique and individual. So when we're looking at an individual, let's explore and let's talk about what makes them individual, what makes them special. The primary characteristics, you can't do anything about your eye color. You can't do anything about your race, gender, ethnicity, age, sexual orientation, physical or mental ability. So you explore it. What does it feel like? Where do you go? What do you perceive as your biggest obstacles? What do you perceive as your biggest strengths? So we're exploring the whole person. When we start off like this, we're taking them away from the substance and we're giving them a reason to stop, to discontinue use. Because people don't use substances to get effed up, stick a needle in their arm, steal from their loved ones, and blow up everything that they love. And nobody starts off with sticking a needle in their arm. It's usually a graduation. They start off with a lower level, then they find something that works even better, and then something that works more, and then eventually something that staves off the withdrawals. So when we're unwinding this or walking out of the forest, which takes time, we have to go back to where they are. I use a lot of breathing techniques, mindfulness techniques, walking or intentional techniques. And we're going back to breathing. So a lot of people recognize the power of the breath. That's one of the first things that we start. Actually, when we're created in the womb, that's one of the first things that's set up is the breathing. Secondary characteristics: religion, socioeconomic class, education, geographic location, appearance, marital status, parental status, military status, immigrant status, criminal justice system involvement. One of the things with my people who were incarcerated is they don't want to be judged, and they're having a real hard time coming from a cell and sometimes solitary into a world that is just overrun with stimulus. And if they haven't, their last phone was a flip phone, this new environment, which is changing so rapidly, is real foreign to them. So we have to look at exactly where they are and then move them through their stage, wherever their stage is. And the deal is, I'm not making the goal for people. I'm not branding them. I'm not throwing out the label. They are. That's their responsibility. That's their job to figure out what makes them happy, what makes them fulfilled. Now, I'll walk with them And sometimes it gets pretty ugly and gets pretty rough, but at the end of the day, they're not doing it to make me happy. They're doing it to get out of this diabolical health concern. So when we're talking about stigma in clients with substance use disorders, let me ask the audience, let me ask everybody, do you avoid or use any terms with clients who have certain primary characteristics or secondary characteristics? Is there anything that you tiptoe around or avoid? Pretty tough, isn't it? That's a soul-searching kind of question that you don't have to verbally put out there, but you might ask yourself why. You might ask yourself, what do I do to get over that? Or is that actually beneficial? Is this therapeutically beneficial? Or do I need to look at some things inside? And then this one I'm going to ask everybody. And so try to give me an answer real quick. Do you avoid or use any terms with clients who have a substance use disorder? Anybody? Who we got, Troy?
I don't know, feel free to call on anybody.
Who's? Oh. Human being Gilder?
Out there in Ely, who do we have with us? Willie B. Ryrie? Not sure if we can hear you today. Sorry about that.
All right. Are you talking about terms like alcoholic or junkie?
Yes.
Or
Yep. All right, well, think about that one too.
I can tell you a situation. I mean, we had a patient recently who got referred to us in their primary care note, said history or alcohol abuse or history of alcohol abuse. So in the past medical history in our note, we put the patient has a past medical history, you know, of hypertension, diabetes, alcohol abuse, and it turned out that you know, we never asked questions about it. We just, you know, carried it forward from the referral documents. Patient, you know, at the end of our initial visits, we always give patients a copy of our note, so they don't feel like they have to memorize anything. You know, we'll take this home, we can look at it. We get a phone call the next day, angry. How dare you call me an alcoholic? I'm sorry, we just carried forward your primary care notes. We didn't say you were an alcoholic. And patient refused to come back and see us ever again. Based off of, they felt stigmatized.
That'll do it. Let me go to this last one real quick. Here's the answer. Talk to the client. The screening, assessment, diagnosis, and it's all communication. Consistent through questions, consistent thorough questions allow the healthcare provider to obtain a snapshot of where the client is in different areas and stages of his life to treat the whole person. Communication with the client helps change the perception and transference from the healthcare provider, and knowing the whole person broadens the healthcare provider's lens. So that's it. It's talk to them, one-on-one, human beings. Sorry we went a little bit over. I had to, we got a little bit older together. I appreciate y'all getting older with me, but I had to wrap it up with some therapeutic resources there. So just yeah, communicate. You're dealing with an individual. They're much bigger than the substance use, and really want to thank you all for being here. And next time we have Dr. Lewandowski.
Yep, but before that, actually, next Thursday, we're going to have a talk on Assembly Bill 474. That'll be next Thursday at 8 a.m. All right, thank you, everyone.
I'll pull it up.
And my apologies, William B. Ryrie. I'll follow up and make sure we can get your question answered. Yeah, I just don't think we have audio today. Thank you.